an injectable. This one is taken by people who are not HIV infected, people who are not living with HIV, and they can take one single pill every 6 months. And again, if somebody takes this pill, it will completely prevent infection. So in the clinical trial that is described there in this study, those people who took lenacapavir, none of them got HIV infected. So it has a 100% ability to prevent HIV infection, almost as good as any vaccine out there. So we have made a lot of progress. So maybe you are asking yourself, then why am I here talking about curing HIV? Well, the problem of HIV has been solved. The truth of the matter is that the problem has not completely been solved, and this is data from KwaZulu-Natal that I'm showing. I work in KwaZulu-Natal in Durban, in South Africa. And this is a study that we did a few years ago that shows that the percentage of people in a district in northern KwaZulu-Natal who are living with HIV, if you look at the age group between 25 and 44, you can see that 40% of women and 60%, 40% of men and 60% of women have HIV in KwaZulu-Natal, in Mkanyakunde district in northern KwaZulu-Natal. That means that these individuals will have to take antiretroviral drugs for the rest of their lives unless we can develop an HIV cure. So I think it is really important that we should develop a cure for people who are living with HIV. And then the other problem we have is that although the number of new HIV cases has been going down, we are still way above the target. So in 2024, we had about 1.3 million new infections, and yet WHO had set the target of about 500,000 new HIV infections. So essentially, we had 3 times more new infections than what WHO had targeted. So we have way too many new infections still happening even today, primarily because people are not adhering to antiretroviral medication and people don't know their HIV status. And so that means that HIV is going to continue to be a problem with us, and we need to look for a cure for HIV. So what are the solutions for ending HIV as a public health threat? The first one, of course, would be to develop a vaccine or immunotherapy, one that you can just give once or a couple of shots and then somebody is completely protected, but we don't have a vaccine yet. There are other ways that we have been looking at. For example, it's been noted that the vaginal microbiome can determine a woman's health, and women who have a more diverse microbiota are more likely to acquire HIV infection. And so there's a lot of research that is going on to try and understand how you can modify the vaginal microbiome so that women have Lactobacillus crispatis, which is the normal vaginal microflora, instead of the more diverse anaerobic bacteria that some women have that facilitates acquiring HIV infection. And then, of course, the third approach, which is what I'm going to talk to you about today, is to develop a cure for HIV. So I think, as I mentioned, antiretroviral therapy is very, very effective. It can suppress viremia to undetectable levels in somebody who is taking antiretroviral medication. The problem is that as soon as you interrupt antiretroviral therapy, the virus rebounds. It comes back within 2 to 3 weeks. Now, why does the virus rebound? The virus rebounds because when somebody is taking antiretroviral medication, you have not really completely eradicated HIV from immune cells. So there is HIV that is hiding within immune cells, and we call that HIV the reservoir. And as soon as you interrupt antiretroviral therapy, that reservoir is reactivated and the virus starts replicating again. So in order for us to get rid of HIV, what we need to do is to get rid of that reservoir of immune cells that contain HIV that is latent. And this has actually been achieved for a number of people through gene therapy approaches. So for example, we have about 11 people who underwent bone marrow transplants, and they received the donor blood, the donor cells, from people who do not express CCR5. Now, CCR5 is one of the core receptors that HIV uses to enter cells. So HIV uses two receptors to enter immune cells. One of those receptors is CD4. The other one is a chemokine receptor called CCR5. But there are some people who naturally do not express CCR5 because they have a mutation within the CCR5 gene, the delta 32 mutation. And because those people don't have CCR5 being expressed on the cell surface, those people cannot then be infected by HIV. Unfortunately, those people are less than 1% of the global population. And most of those people are of North European genetic background. So, unfortunately, again, bone marrow transplant is not something that you can do for everybody. So these are the people that have been cured of HIV that are shown here, some of them. So there are actually up to 11 people now that have been cured of HIV through this bone marrow transplant approach. So these individuals got a bone marrow transplant from people who did not express CCR5 receptor. So, but bone marrow transplant are not the only ways to actually cure people of a disease like HIV. There are other gene therapy approaches, but these gene therapy approaches require that you take cells out of the body and that you genetically modify the cells outside the body, for example, by eliminating the CCR5 molecule, or by through gene editing approaches like CRISPR-Cas, you can cut out the HIV genome from cells. But you have to take the cells out of the body, and this is a very expensive procedure, and it's not safe. It has a lot of complications, so this is not a proper, really a public health approach. People are also trying to develop other one-shot gene therapy approaches. For some reason now my cursor will not work. I think I may have run out of batteries here. But what I wanted to say is that as I hopefully I can, yeah, okay. Let me go back. Yeah, so I just wanted to say there are other gene therapy approaches that people are trying that are one-shot gene therapy approaches, but again, those are not yet ready for prime time. So nobody is using these kinds of approaches, at least not in the clinic, although they're being used for research purposes. So what is the other way to cure HIV? So the other approach to curing HIV is to use antiretroviral therapy to reduce the size of the reservoir, these immune cells that contain HIV. So you can reduce the number of those cells by giving many years of antiretroviral therapy. And then once you have controlled that reservoir, the immune system can be boosted. The immune system of the person living with HIV can be boosted so that the immune system itself is now able to control the virus below undetectable levels without the person having to take antiretroviral medication. Now, this approach actually has been shown to work. It's not a complete cure because it doesn't completely eliminate HIV from the body, but it is the person can go into remission so that they don't have to take antiretroviral medication, perhaps for a year or two, or even for more than 2 years, and still live a healthy life and not be able to transmit that virus to somebody else. So this approach, where you give antiretroviral therapy and then boost the immune system, has been shown to work, particularly when antiretroviral therapy is started soon after somebody acquires HIV infection. So if somebody starts taking antiretroviral medication within 6 months of acquiring HIV infection, they are more likely, this approach is more likely to work in that person. So the way this approach works is that you've got these latently infected cells, the reservoir that I talked to you about, you can activate HIV from those reservoir cells using drugs that we call latency reversal agents, and then you boost the immune system either through broadly neutralizing monoclonal antibodies or through vaccines, and then that immune boosting will then control the virus by itself. So we wanted to test and see whether this approach could work in Durban, South Africa. And in Durban, as I mentioned to you, we have very high rates of HIV infection, particularly when we started doing this study about more than 10 years ago. We started a cohort that we call the FRESH cohort. And in this cohort, what we do is that we recruit young women between the ages of 18 and 23. And most of these women are coming from disadvantaged background. So we wanted to do something that would benefit them socially. So we introduced a curriculum where they come into our clinic twice a week. They learn how to use computers. They gain other life skills. And we actually even try and connect them to job opportunities. But when they come into the clinic, we take a finger prick blood draw. And because all these women, when they come into our study, they are HIV negative. If somebody acquires HIV when they're in this study, we will be able to tell immediately because we are testing them every 2 days. So Tuesday, we test them, and we test them again on Thursday, and we test using PCR, a PCR assay. So if somebody acquires HIV, because these women are going about their normal lives, then we will be able to tell that they have acquired HIV immediately. And then, of course, this study also involves taking blood samples so that we can study the virology of the virus, but also immune responses in people who acquire HIV infection. So we call this study the FRESH study, and we embed a lot of HIV prevention messages. But despite the best of our efforts, some of the women still get HIV infected. So we have followed about 4,000 women since we started this study in 2012. And we have had about 113 women that acquired HIV infection. So as I mentioned, what we do is that we follow HIV negative women. We test them twice a week. And some of them do acquire HIV infection. The first 14 women that acquired HIV infection, we did not give them immediate antiretroviral therapy because at that time, in 2012, we were following the South African guidelines for antiretroviral treatment. And at that time, the national guidelines say that you should start treatment when the CD4 counts fell below 350. But since 2015, we started treating everybody immediately after they acquire HIV infection. So if we notice any acute HIV infection, we call them, and within a day of detecting acute HIV infection, we start antiretroviral therapy. So these women are being treated very, very early. And if you look at their CD4 counts, or even their viral loads, they look almost like, if you look at the CD4 counts in particular, they almost look like HIV negative individuals. So this cohort, we also take not only blood samples, but also we also take gut biopsies, lymph nodes, and so on. And we have now conducted 2 clinical trials in this study, and I'm going to tell you about one of those clinical trials. But as I mentioned, since we started this study, we have had about 113 women that acquired HIV infection. Most of them started antiretroviral therapy within a day of detecting acute HIV infection. So very, very early. In fact, when we started this study and when we started offering antiretroviral therapy, we thought that we could cure HIV and prevent HIV from establishing in these women because we were treating them so early. But what we have subsequently learned from this study is that no matter how early you treat, the person still, the virus is able to spread because the reservoir has already been established. So what have we learned from this study? The first thing that we learned is that if you start treatment very early, the viral load, of course, goes to undetectable within about 2 to 3 weeks. And that's what is shown there in the blue and red lines there. So those are the women that started treatment immediately, whereas the black line that you can see there is the viral load of the women who are not treated immediately. So those women have high viral load as you would expect, because they are not on antiretroviral therapy. And we also noticed that if you started treatment very early, you could blunt the peak viremia. So when somebody gets HIV infected, the viral load in the first 2 weeks, 2 to 3 weeks, goes up to about 10 million copies before it comes down to what we call a viral load set point, and the viral load set point is about 100,000 copies. But for the women who start treatment early, the peak viremia is not 10 million, but is actually about 10,000. So we are able to blunt peak viremia. And we also could show that the CD4 count of these individuals was much higher than for the women who are not treated immediately. So the native CD4 count is much higher for the women who started treatment during acute HIV infection. Now, as I mentioned, we start treatment so early that these women do not seroconvert. So when you go to if you go to a clinic to be tested for HIV, they'll do a rapid test, which is an immunoassay, or they do an ELISA to see whether you have HIV infection. These women, because we started treatment so early, they don't actually seroconvert. And you can see there in the blue dots that most of them remain seronegative because they have had very little exposure to HIV antigens. Whereas the women, the first 14 women that we identified with acute HIV infection, all of them seroconverted because we were not offering immediate antiretroviral therapy. This is a complicated figure, but I wanted to show it because one of the advantages of having this study was that we could actually test the virus that was transmitted in these women, the very virus that established HIV infection, and test that virus for susceptibility to broadly neutralizing monoclonal antibodies. And what we were able to identify is the two broadly neutralizing antibodies, one called VRC07 and another one called CAP256. So these are very, very potent and broadly neutralizing antibodies against HIV envelope, and they can inhibit the virus even without antiretroviral drugs. So we were able to identify these two BNAbs, broadly neutralizing antibodies, as being very, very effective against the viruses that established infection in these women. Now, why am I telling you about these two broadly neutralizing antibodies? Because we then designed a clinical trial where we wanted to see what would happen if we give these two broadly neutralizing antibodies to these women who started treatment very, very early, who had very little exposure to the virus, and whose immune system was quite good. Could we actually stop the virus from rebounding? So we did a clinical trial, and the idea behind this clinical trial was to see whether in these very early treated women, whether if you give them the two broadly neutralizing antibodies and a latency reversal drug, a toll-like receptor 7 agonist, which is a latency reversal drug, could you delay viral rebound? And if you are able to delay viral rebound, will the person's own immune system be able to control the virus without antiretroviral drugs? So we give them the two broadly neutralizing antibodies and the latency reversal agent, and then we interrupted antiretroviral treatment to see whether the virus would rebound. So I'm going to tell you about that clinical trial, and I'm going to finish by talking about that clinical trial, which was quite exciting because it was the first HIV cure trial done in Africa. So this was the design of the study. It was a small study of only 20 people. As I mentioned, all of them started treatment in acute HIV infection. We then gave them the combination of the two broadly neutralizing antibodies, one shot, and then we gave them the toll-like receptor 7 agonist, which is a latency reversal drug, and we gave them 10 shots of the latency reversal drug, and then we interrupted antiretroviral treatment to see whether the virus would rebound. So the primary endpoint for this study was to see whether this combination of drugs was safe, but the secondary endpoint was to see what was the time to viral rebound, and also to look at the viral load set point once the viral rebound happened. So I'm going to skip that because of time, but just to show you that when we give the two BNABs, VRC07 and CAP256, we could actually detect their levels inside blood, and we could demonstrate that their levels were above the therapeutic dose. So they should be able to inhibit virus replication. So what were the results of this trial? Basically, there were 3 groups of participants. I told you we started with 20 participants. What we saw is that 7 participants rebounded quite quickly. Even when they had antibody in them, within 16 weeks, the virus had already rebounded once they interrupted treatment. And then we had another group of women, again 7 women, who rebounded after the antibody had started waning. That's when we were expecting most of the women to rebound, because that's when the antibody was now waning. And again, remember, they don't have any antiretroviral drugs. And then we had the third group of women, 6 of them, who stayed for 1 year without needing to restart treatment. And 4 out of 20, which is 20%, were completely suppressed at 1 year after they interrupted treatment. So just to conclude here, this was the first HIV cure trial in Africa, and it demonstrated that this kind of complex studies can be successfully conducted in Africa. Of course, this study was a very complex study. It required a lot of community engagement and community education. The treatment itself was safe and well tolerated. I didn't show you the safety data, but it was quite safe and well tolerated. And as I mentioned, 4 out of 20 women, which is 20%, achieved durable control of the virus without antiretroviral drugs for more than 1 year. And in fact, we continue to follow them after 1 year. One of those women is still off antiretroviral therapy about 3 years after the interrupted treatment. And we are doing a lot of studies now to try and understand why some women controlled and some did not control. We have also done a lot of social behavioral research work. So just to summarize, that this is a proof of concept study, and it demonstrates that an HIV cure or remission is possible. Immunological approaches like the one that I just discussed can work, and they can induce responses, but we need to do more to understand the underlying mechanisms. And we need to do more of these kinds of studies in Africa in order to move towards an HIV cure. And I also just wanted to say again that this kind of work requires a lot of community and public engagement. So, for example, when we reported these trials, we had to do a lot of community engagement with the government of KwaZulu-Natal in order to explain people. In fact, on the internet, there was some talk that I should be placed on under surveillance and on security, so that I can be protected, because people might kill me because I have a cure, but I'm not sharing it with everybody else. So this was not a cure, and we needed to explain that to the community. So we had a lot of community engagement. But I also wanted to say that this work has also led to us developing guidelines about how to do these kinds of studies in Africa, including revising the global guidelines on how to do these kinds of studies so that we can advance the science, but also protect participants, because obviously there is some danger when somebody interrupts antiretroviral treatment. So we have recently developed the global guidelines on how to safely interrupt antiretroviral treatment, and this paper has been published recently in Lancet HIV. So this is my last slide. I just wanted to say that we have made a lot of progress in HIV treatment and HIV prevention. There are many modes of doing this, and we need to work more in terms of implementing these tools that are now available. But I also wanted to say that innovation will be required in order for us to end HIV. The current tools we have will not be enough. So we need to, for example, think of how we can modify the vaginal microbiome. And there's a lot of research going on in that area. I hope that particularly the younger vets who are here can be part of this work. There's a lot of work on vaccines and passive immunization. And of course, I told you about HIV cure strategies. And then finally, I wanted to acknowledge people in my laboratory at the Africa Health Research Institute and at the HIV pathogenesis program at the University of KwaZulu-Natal. And also this study, this work has been a huge collaborative effort involving colleagues at Gilead Sciences, people at the University of KwaZulu-Natal, the Reagan Institute, the NIH, and of course, I also wanted to acknowledge the many funders who have helped us and supported our work through many years, some of whom are listed here. Thank you very much. I'm happy to entertain questions if there is time for questions. Thank you.
I have a question regarding the sensitivity of allowing yourself to be infected with HIV voluntarily. Excuse me, for the first study you said that you recruited negative women. They contracted the HIV on their own. But what about these studies that we've had over time that people are being recruited, they are paid, and then they allow themselves to be injected with the HIV virus? Are those true, or they are just fallacies and myths?
I have a question. I don't know if, did you say what the drivers of the high prevalence of HIV in KwaZulu-Natal? If you say that, I may have missed that. So what are the factors that are causing the prevalence of the virus to be high in that province?
Okay.
My name is Professor Mbui, Dean Vet. Now, Dr. Thumbi, thank you very much for that good talk. Now, I want to know why you did not include men in that study. Were the women aware of that, whatever you were doing with them when you enrolled them? Did you discuss with them first before you started testing, or they were just coming for training only? So what happened when they diagnosed positive? Did you follow their boyfriends, girlfriends, husbands, to come and be tested also and then be treated? Or is that ethical anyway if you did not do it?
Okay, maybe I can take those first so that I don't forget, and then we'll go to the next one. First of all, I think the idea of infecting people with HIV so that you can do research is it's a conspiracy theory that people have. There's no ethical board that would allow you to infect people with HIV so that you can study them. That's absolutely not what we do. I don't know of any ethics board anywhere that would approve a study of that kind. So that's a complete lie, if I may say so. Nobody gets exposed to HIV, live HIV, so that we can do any kind of study. What we do, and now maybe to address Professor Ombui's question, is that what we have done is that we knew, when we started this study in 2012, we knew that the rate of HIV infection was very high among young women between the ages of 18 and 24. So we knew that if you follow women in that age group consistently and test them regularly, some of them, because these are women, individuals in the society who are going about their normal lives, that if we follow a group of women, we are likely to get some acute HIV infections. So if you follow 100 women in this community, because of the high rate of infection in young women, some of them are likely to get HIV infected. And that's exactly what we did. So we recruited them. We told them that we were doing a study. The purpose of the study was to understand what happens in acute HIV infection. So we explained that to them, and we told exactly what we would be doing. We told them, you are HIV negative. We told them about all the ways to prevent HIV infection. We gave them condoms. we tell them about HIV prevention every time they come into the clinic and how they should prevent themselves from getting HIV infected. But despite that, because people are going about their normal lives, some of them will actually get infected, and that's exactly what happened. So we were able to pick some who got HIV infected. So this was a completely ethical, it was completely transparent. We told the women what we were doing. We told them that we were looking for acute HIV infection. If they did get infected, that we would enroll them into an acute HIV infection protocol. And we told them that they are HIV uninfected, they should protect themselves, but that we will be testing for HIV infection with PCR every 2 days. So as they come into the clinic to learn how to use computers, we also take a finger prick blood draw and we test. And actually, that's exactly what happened. And when we actually investigate the history, because once somebody becomes HIV infected, we offer them counseling. Some of them will tell us about the sexual experience that they had with a boyfriend or with a new partner that they didn't know that they had HIV. So, yeah, so it's not an easy study, but we took it through all the ethics boards at the University of KwaZulu-Natal. This study was also approved by all the ethics committees at our other institutions. Just to answer your question about why is HIV so prevalent in KwaZulu-Natal, I think it's very complex. It's a very complex socioeconomic, I would say socioeconomic. There are high levels of violence and deprivation in some of the communities in KwaZulu-Natal. There are socio-cultural practices that make women more vulnerable to HIV. Socio-cultural practices, the Zulus traditionally did not practice male circumcision, which has been also shown to be protective against HIV infection. So I would say it's a very complex set of factors, and it's both biology but also social factors.
Yeah, my name is Charles Ochodo. 2 questions. The 11 Caucasian patients that got cured, they were initially sick, they had HIV, and they were treated and they got cured because of their blood characteristics. Which are the pills that were used to cause that cure? And would it be possible to cause the blood of people, particularly Africans who do not have that kind of blood? Would it be possible through gene editing to get Africans to have that kind of blood so that they can also be able to attain the cure using the pill that was used? And the last question, lenacapavir was recently launched in the country, and as you have indicated, it's for people who are not HIV positive, but taken every 6 months. It can be used to prevent HIV infection. What prevents the world from using this as a prevention method for HIV by doing mass testing and administering this medicine to people who are HIV negative? Because then we'll be creating a pool of people who can then act as a barrier to infection and propagation of the disease.
Let me answer that first. I think that the people who have been cured of HIV is because they received the donor blood was from somebody who was CCR5 delta 32 homozygous, so they did not express CCR5. And of course, anybody can get that kind of donation, but you have to get a donor that matches when every time you're doing a transplant, a bone marrow transplant, you have to get a match, and that includes HLA matching. So it's not an easy procedure to do, and there are likely to be complications because of rejection. So although it can work theoretically, it's not an easy procedure to do, and we don't have the resources because, as you know, doing a bone marrow transplant, even in resource-rich countries, it costs millions of dollars. So it's really not feasible as a public health approach. So, but there are people are thinking about doing gene editing to, for example, knock off CCR5 expression, because there are some people who don't naturally express CCR5 and they seem to be normal. They don't seem to have any health challenges. So there are approaches that are going on to try and see whether this can be used as a gene editing approach. In terms of lenacapavir, I think one of the things that we learned from COVID is how complex this kinds of decision making is. If you try to force people to take lenacapavir everywhere, you'll be in a lot of trouble. Because people don't want to be forced. Some people believe that they are not at risk for HIV infection, and you don't want to force anybody to take any medication to prevent HIV infection. Remember, even something like HPV vaccine, which has been shown to prevent cervical cancer, and is very, very effective. We still have people who are opposed to it, even in this country, people who are not taking HPV vaccine, which prevents cervical cancer. So you can imagine if we try to force people to take something like lenacapavir, whereas some people don't believe that they are at any risk of acquiring HIV. So I think this is not something that we should do. I think we have to persuade people to assess their own risk, and then if they feel they are at risk, they go and get the medication. We cannot force people, because otherwise it will cause a lot of social tensions, I think, and people will... there will be a riot, I can assure you of that.
Yeah.
Okay, I think we close.
Just one more.
Let's close kindly. It's late.
Thank you.
And I think you can always interact with him. Prof, how long are you here?
I'm here until tomorrow lunchtime.
Okay, please interact with him. I also had a question, but I will leave it so that we can break. I think we are going to have Samantha. We are. Okay. Let me hand it over to the chairman to give us the way forward.
Thank you so much, Prof. And thank you, Prof. Thumbi, for that captivating presentation. Colleagues, I know you're very tired, and we are very sorry for that. Our intention was to keep you here up to latest 4:30. We are way beyond schedule. We have cocktails starting at 6:30, 6:45, as invited by Dr. Asoka Itur. At 6:45, where is the venue, Dr. Opere? By the beach, there's a restaurant called Coral Restaurant. If you can freshen up, okay, but if you can't freshen up because of time, do not worry, nobody's going to judge you. We are at the coast. So see you there at 6:45 to enjoy some cocktails and networking. Sawa. In addition, tomorrow's session begins at, just a minute, please, 8:05, as invited again by Dr. Itur. Tomorrow's session begins at 8:05. Colleagues, today we began a bit late, 10 minutes late, because this was a partner's presentation. Tomorrow, you come late, you're not going to get your initial points. We are beginning exactly at 8:05 to avoid this drama of leaving the Congress at 6 p.m. I want to take this opportunity to thank Professor Thumbi Ndungu There are two Professor Thumbis, so I keep confusing them. Professor Thumbi is also, I was just pointing to Professor Kimwele, recently inducted in the US National Academy of Medicine last year. Thank you for flying the flag high, Prof. Please interact with him if you can later on. We have elections tomorrow. The interim electoral committee is going to make announcements tomorrow on how you're going to conduct those elections. I believe that is it in terms of closing remarks, Dr. Mwasia. All right, so colleagues, see you at 6, yes? Okay, I've been informed that we have not prayed. Okay, so let's have a prayer from Dr. Sakwa, and then we'll be free to leave. Please ensure you sign for your points as you leave. There are people who are leaving without praying. Karibu.
Okay, thank you. So let's pray. Lord, we approach our throne of mercy this evening. Thank you for the interactive day that we've had. Thank you for the gift of life. Thank you for the strength that even as we disperse to our different destinations, as we go for the cocktail, we also pray for your guidance. And shall we meet again tomorrow? We shall give you thanks and honor. And this I pray in Jesus' name. Amen. See you by the beach. And enjoy yourselves.